Good afternoon. I'm Elizabeth Reynolds, and I'm president of the Virginia Dental Association. We recognize that these are unprecedented and uncertain times in our dental profession. The VDA and the ADA are devoting our full efforts to making sure that members have the resources they need to successfully manage through these rough waters. The VDA and ADA have both issued a recommendation to postpone non-emergent care, and that recommendation has been also echoed at the federal level as yesterday and again today. We expect to have further guidance from the CDC and ADA soon, but in the meantime, you will continue to find updated resources on managing your practice through these challenges, including employment issues, state and federal assistance programs, and more on the VDA website as they become available. We're working very closely with our national and state level partners to get the answers to all of your questions and to provide additional resources for your practices. The ADA is aggressively lobbying at the federal level to make sure that dental offices are taken into account in any legislative relief package, and we are doing the same here in Richmond. On a personal note, our practice has been going through the same difficult decisions that many of you have. It is painful knowing that your patients depend on you for care and your employees depend on you for their livelihood. Know that we are all in this together. In these times, it is more important than ever to have a strong voice advocating for the profession in the VDA, and I want to thank so many of you for offering help, encouragement, and leadership as we get through this. The team at the VDA has been incredible, working day and night to ensure you have all the information available. I would personally like to thank them and ask that you do the same when you have the opportunity. Today, we've gathered some of the brightest minds in the profession at the VCU School of Dentistry to address the questions we've been hearing from the VDA members. Part of the way we will get through this is with a shared understanding on some of these key clinical issues related to the virus, which our colleagues here will be covering in today's webinar. Please allow me to introduce Dr. Dave Surratt, Dean, VCU School of Dentistry. Dr. Surratt, thank you for being with us.
Thank you, Elizabeth. We really appreciate the support and the collaboration. And really, it's hard to believe that none of us knew we'd be here a few months ago. In fact, we probably a few days ago, we didn't think we'd be in this position. But you know, the issues going on in the community, our clinics, our homes are very challenging. Elizabeth mentioned teamwork and communication are absolutely critical. The past 5 days here at the dental school has been an up and down waves of communication, of things, changing information. So it's been quite a challenge. As dentists and other dental team members, we reached out to the Virginia Dental Association and offered the VCU School of Dentistry to share what we've learned, to provide guidance where we can, and to answer as many questions that we've heard from you. And we do hear you. We're together with this, and we'll get through it together. As you know, routine patient care has been paused in our School of Dentistry clinics, just as it has in your clinics and offices. As we continue to provide urgent care, the decision is consistent with emerging national and statewide guidance, but could change literally in a heartbeat. And in fact, some of our thoughts have even changed this morning as we were reviewing additional information. So with that, let me introduce the folks that are going to be speaking, besides myself. Ellen Burns, Senior Associate Dean for Academic Affairs. Ellen, if you'd raise your hand there. Rick Archer, Senior Associate Dean for Clinical Education. Mike Healy, Senior Associate Dean for Student Affairs. Kim Isringhausen, Associate Dean for Risk and Compliance. And Tegwin Brickhouse, Chair of the Dental Public Health and Policy Department. These are uncertain times. We're here. We're going to get through it, but it's going to be a tough time, and we all need to work together. So, Elizabeth, I think you're going to introduce the first question.
I am. What do we know about how COVID-19 is spread, and specifically how to prevent that transmission in a dental office setting? Kim, could you answer this for us, please?
Sure. Thank you, Dr. Reynolds. You know, in general, we know that the virus has been spread through travel-related transmission. Those are imported cases that have been brought back into our country. There's person-to-person transmission. That occurs between people who are close together, within 6 feet of one another. one individual is infected with the virus, they cough, they sneeze, the uninfected person inhales those respiratory droplets. That 6 feet is where we came up with the social distancing that everyone is talking about and practicing now. And then there's transmission through community spread, meaning that there's people in an area who have been infected, but some of those people don't know how they became infected. So I think when you look at the dental office, there's a tremendous risk of COVID-19 infection because the virus can be transmitted through face-to-face communication, that person-to-person contact. It can be transmitted through direct contact with oral fluids, blood, and saliva that generates aerosol, and indirect contact with contaminated instruments or environmental surfaces. So again, we have that airborne spread. We do a lot of procedures in dentistry that generate aerosol, and it's really hard to avoid that aerosol production. Those aerosols and droplets actually stay airborne for an extended period of time, so that makes it even more risky because they're going to remain in the air even when you're not doing a procedure. We have that contact spread. Again, we are in contact with fluids, patient materials, our dental instruments, environmental surfaces. And so this type of spread can happen actually through contact with your eyes, your nose, your mouth. It could be that a person coughs and propels the droplets through the air, and you inhale them, you touch a contaminated surface, and then you touch your eyes, your mouth, your nose. So again, contaminated surface spread, we're touching things. And I think there's a slide coming up in a little while with the most recent evidence to support how long the aerosols stay in the air, which could be up to 3 hours, as well as how long the virus lives on surfaces, anywhere from 4 hours to 2 to 3 days. The other thing I'd like to mention is the risk of transmission from asymptomatic patients. There are a number of individuals with no symptoms. They shed the virus and they spread the virus. So I think that's probably one of the bigger risks. I know that you asked, how do you prevent this type of transmission in the dental office setting? And I think we're going to talk more about that throughout the conversation today. But the most important thing is to be familiar with how the virus spreads and then screening patients for suspected infection, taking temperatures, asking screening questions. If people answer yes to those things or they have a fever, you would want to defer your treatment. If they answer no, I just kind of put a pause there because, again, you don't know about that person that's asymptomatic.
Thank you so much.
So Dr. Archer, Rick Archer, what is the science behind the decision to pause non-emergent care in the dental office?
Yeah, thank you, Dr. Surratt. This is certainly a question that if I was in private practice, I would really be asking. I was in private practice in the Tidewater area of Virginia for 16 years and practicing endodontist. So this is something that we obviously always think about as a practicing dentist. We always use the term universal precautions, where we try to treat everyone like they're infected. And we practice good infection control. We wear proper protective devices. However, this is really a new situation in dentistry. And there's very little that we know. And what we do know is coming out of China, because they obviously were the first ones to experience this. So this study, which was just published last month in the Journal of Dental Research, came out of China and really kind of gave us our best evidence for trying to limit treatment to emergency treatment. So at this dental school and dental hospital, it was very, very large. They treat 890,000 patients a year. They have 1,098 staff members and 828 dental students. So it was a huge clinic. When they were undergoing their regular operations, in their regular protocols, they had 9 dental professionals that became infected. And I think we have a slide coming up that shows that. And this was through January of this year. On January 24th, they made the decision to only treat the emergent needs of patients coming in with pain and emergency, and that was over 700 patients. And when they started limiting their practice to emergent patients only, they had no new cases diagnosed with dental professionals. So I think that's pretty good evidence that from what we know that shows that one of the ways we can limit this is to try to limit our patient population to those who absolutely need it. This is the list of the professionals that came up with it and the dates that they did. They were all separated except for the two nurses. Apparently there was some cross contamination with those or a crossover with those. But as you can see, there are the 9 that did come up positive. But once again, after they initiated the protocol treating only emergent patients, they had no new ones. And you can advance the slide. Okay, this slide is actually, it looks very complicated, but it does tell the story of what happened in the hospital. So if you look at this graph, you can see the blue bars are actually the patients treated in the dental school, and you can see they're running dates in December and January up through January the 22nd there. Quite a few cases were treated. The overlying yellowish orange line there is the actual cases of coronavirus in Wuhan, and you can see that they dramatically increased after January the 22nd. Remember, January the 24th was the date they instituted emergent care only. And you can see once the cases in the hospital dropped off there, the population levels of infected individuals went way up, but there was no increase, in fact, no cases of professionals that developed the virus. Next slide.
So I'll take the next question. And actually, I'd like to back up one slide. The other direct, yeah, back to the Wuhan slide. So, so before we leave that, Dr. Archer, this morning you and I were talking about what their actual protective protocols were. And although the article is well written in English, but as you can imagine, they're coping with these things. It sounded like, to me at least, that they also instituted the use of N95 masks for at least some of their procedures, as well as screening patients, as well as limiting urgent care. So they had several things going on. So that caused the reduction. It's hard to pick out what were the most important components there. So
yeah, that's correct. They also worked in isolation rooms, were very particular in the way that they cleaned the rooms. And that was instituted after this January the 24th date. So there were a number of factors that went into protecting the providers. Okay,
great. So we'll go to the next one. So do the recommendations from the VDA, the ADA, and the VCU School of Dentistry that the universal precautions that every dentist practice are insufficient to prevent the transmission of this virus? A week ago, I would say I, and I think others on my team, were less concerned. I think as we learn more about the Wuhan school and other things come out, we are becoming a little more uncomfortable. We just have to be honest with you. So this study was a pre-published manuscript that has been sent for publication, but the authors shared it because they thought it was very important. And basically, it's a lab study investigating the stability of the virus, both in the air and on surfaces. And I highlighted there in yellow the most important part, and said that we found virus could be detected in aerosols up to 3 hours post aerosolization up to 4 hours on copper, up to 24 hours on cardboard, and up to 2 to 3 days on plastic and stainless steel. Then if you think about this, the surfaces, obviously, we can clean. Well, the good thing, my understanding, is that it's very easy to kill it with alcohol and bleach, and even soap and water does a good job. So surfaces we can do a good job with. It's the 3 hours that it's still floating around in the air and potentially infective that has kind of raised our concern. Next slide. So this article also delved into some of the very same things that Kim Isringhausen was talking about, as well as giving a little more guidance on what to do to try to practice safely. They're recommending you learn to identify a suspected case. Now, that doesn't mean you become a diagnostician. That's got to be left to the experts, but certainly understanding what a patient who presents with this disease, the most likely symptoms are, I think it's very important if you're going to be practicing dentistry. Measuring body temperature with a contact-free thermometer is the best. We've implemented that in our screening. We don't let anybody in the dental school now, staff or patients, unless they've been had their temperature taken. A questionnaire that's been mentioned already to screen for travel-related history, as well as current illness and current health. We have one that we have been updating regularly because the actual criteria change from day to day relative to travel history. I think was really getting to where if anybody's hardly traveled anywhere domestically now, been on an airplane, they're likely to have been exposed. If the screening questions are negative, temperatures below 99 degrees Fahrenheit or 99.1, then treating the patient with emergency procedures, taking extra cautions to prevent aerosol generating procedures seems to be recommended. This is what we have currently on our website. It was updated this morning with the list of criteria that what falls under urgent care. And you can see those, we added those. We're still doing the screenings at the door on the questionnaire, as well as taking temperatures. And if you want to go to that website, you can actually see this, on our website. So recommended treatment protocols, strict patient screening, hand washing, PPE, recommended that 1% hydrogen peroxide rinse is effective. Use of rubber dams where possible. High-speed evacuation is very critical. Extraoral radiography where possible, because patients might cough getting a radiograph made. And then we don't have it on the slide, but we've stopped all Cabotron use until further notice, because that is one of the most, the procedures that generates the most aerosol. Next slide.
Dr. Brickhouse, as an epidemiologist, should different regions of Virginia react differently with regard to their response? And also, how does this compare with the past public health crisis that affected the practice of dentistry?
Great. Well, I'll start with that. I guess when we talk about COVID-19, we think about it versus SARS, the bird flu, or MERS, the Middle Eastern virus. So again, the airborne transmission or formite transmission, which is touching, were thought to play important roles in epidemiology of both these viruses that emerged. This airborne transmission has been responsible for the largest super spreading event during the SARS epidemic, which was 2002, 2003. And then these super spreading events were linked to some aerosol generating medical procedures. And again, formite transmission was suspected during the SARS epidemic. And it concluded also that some of the formites, which are, the things that are left on surfaces, have also played a significant role. Next slide. Yep. I think what's different or more difficult about COVID-19 is that the epidemiology is slightly different, and it's been mentioned earlier, but there's a very high viral load in the respiratory tract. And again, the ability of individuals infected with COVID to shed and transmit the virus while they're asymptomatic. I think that's one of the big differences between the two, is that SARS really was spread in sort of a medical setting, while COVID seems to be spreading more in a community-based setting, and probably because we're more aware of it now as medical professionals and are managing it. Again, as mentioned before, the COVID virus lives up to 3 hours in aerosols in the air. And yesterday, the study that Dr. Surratt mentioned was released. It'll be in the New England Journal of Medicine, and I put the press release link there, but you can go to Google Scholar and download the full study if you want to read it. Moving on to kind of thinking about Virginia, this is the map of today's current cases and where they are in Virginia. You know, you can see where the hot spots are. I think this rate is going to change a lot over the next few weeks, because right as of now, there's been very, very little testing and no sort of community-based testing. So I think that when you look at the distribution, it's not that there aren't any cases in other parts of Virginia or Southwest Virginia. I just think they're there and have yet to be detected.
Hey, Ted, can I ask you a question on that? We go back. I was looking at this yesterday, and I believe what struck me, I said, hey, that's the I-95, I-64 corridor. And I don't recall seeing that one that's a little bit west of there. I'm not sure which county that is, but it's kind of sitting out to the left there.
Yeah.
I don't think that was there yesterday, which means it's moving towards the western part of Virginia.
Yeah, and I think, I mean that is the I-95, in addition to how our the demographics of Virginia are, where the more densely populated areas are in Virginia. When I click on that locality, let's see what it tells me. I'm not sure. Can't quite tell which one that is.
Like that maybe out near like Farmville or something like that, maybe, I don't know. But
Yeah.
Maybe Prince William, is that down there? No.
anyway, but I don't think that county was lit up yesterday, I don't believe, but anyway.
All right. Here are some, I guess, current projections for Virginia. Let me get back to where I was. I think I've highlighted March 15th, 16th, and 17th because these are where we had daily numbers and where the testing is starting to ramp up a little bit. And we initially used an infection rate that we then have adjusted, but that kind of shows you about a 0.245 infection rate as an average infection rate over the last 3 days. And I think that's very similar to what they're seeing on a national level. And then we talk about the social distancing. I think that's one of the major drivers in also moving to elective or canceling elective patients and only moving towards urgent care patients, is that social distancing, we applied those rates and it substantially slowed their transmission. And we plot that out. If we would have locked down March 8th, it would have been different, but we locked down a little bit later than that when it came out into the news. And we project that you'll see a slowing of the rate probably around April 5th is what looks projected. And then again, the social distancing and curves for Virginia. This, we try to compare the different percentages of social distancing if that people did it. And China is the blue line, and they were projected to have about a 45% effectiveness of their social distancing. And so we plotted our cases in Virginia thinking that we would have about a 30% rate of social distancing. And, you know, there's a little bit of difference between China and Virginia and the way we live and work. We're not quite as crowded, but they also have stricter government regulations as well. So it'll be interesting to see how that plays out.
So what should I do if a patient comes in and we find out they're infected with COVID-19? Kim, can you guide us on that?
Sure. There's a couple different thoughts here, whether you're talking about somebody who you suspect to be a COVID-19 patient or what we call a PUI. That's where the screening questions that you're asking may indicate that somebody potentially could be infected. So obviously you wouldn't want to proceed with treatment. You would want that person to contact their primary healthcare provider or clinic. But it's very important that you instruct those patients to call ahead. What the physician's offices and the emergency departments don't want is a flooding of these patients coming in who actually may or may not need to be tested. So you'd want to advise them to call ahead. There's also some other numbers I put up here that are good reference numbers for asking questions. VCU Health has a hotline. It's a COVID ID hotline. It actually used to be their poison control hotline, but they've since converted it over to a COVID-19 hotline. So if people have questions, they certainly can call that and ask. The Virginia Department of Health also has a hotline to ask questions. If you actually had a confirmed COVID-19 patient, somebody came in and told you that they had COVID-19, those patients would need to be seen in a hospital setting where there's reverse air rooms and all the necessary precautions to treat someone like that.
Dr. Archer, what about dental offices that do not provide regular dental treatment, such as maybe dental sleep apnea and TMD only cases? They don't use handpieces with aerosols.
I think that, after listening to Dr. Brickhouse, I think her information was incredibly valuable when you looked at those graphs and you realized that social distancing really is the answer to trying to level these curves. And with that in mind, we want to try to limit all contact between dentists and patients if possible. And the medical profession is moved into this too. I was telling the group earlier, my youngest daughter is a pediatric nurse practitioner, and they moved in her office to telemedicine where they're not bringing the patients in, they're doing it remotely to limit that contact. So I think the emphasis here is to try to limit as much social contact as we can. Even though you're not producing an aerosol, you're still touching the patients and having contact there. And I think it's important to try to limit that.
I'd like to come back and add something that I probably could have said earlier, but I'm understanding that there's about 50% of the dentists in Virginia are still actively practicing with the normal operations. And that's certainly kind of scary in terms of not only the risks to the dental personnel in the office, but just what Dr. Archer was saying about social distancing, and you don't know who's a carrier. I think it's something that people really need to start thinking about.
And I'd like to speak to that a little bit. I just think people are kind of in the mode of ramping down their operations, and I think this is a situation where you cease your operations except for emergent cases, and then have the ability to ramp up later. This isn't something that's going to last forever.
So, Elizabeth, I'm going to ask you a question. Are you working at all with the Virginia Board of Dentistry or other governmental agencies that might mandate practice closures except for urgent care or take other actions? And we've also heard from some members, including from our hygiene community, about their CE requirements that are coming due the end of this month, and could there possibly be an extension on that at all? So anything you're hearing from our government agencies?
We at the VDA have been working nonstop in conjunction with being in touch with the governor's office, as well as the Virginia Department of Health. We've been trying to reach out to the Board of Dentistry as well. I think they seem to be waiting to see what happens on a more national front. However, just today, the CMS administrator, Seema Verma, I believe she is called, announced regulations limiting non-essential elective medical and surgical procedures, including dental procedures, in order to help prioritize essential health activities. She did that at one of the president's press conferences today, and I think that speaks volumes as to what we as a profession can do to help curb this pandemic. As far as the what was the other question? I'm sorry.
About CE requirements.
As far as the CE requirements, honestly, that has not been a question that I've gotten yet. We will certainly reach out to the board and see what we can do and see if we can get them behind us to help our colleagues in that.
I do have a suggestion for that. And we're becoming quite good quite rapidly at online teaching and pumping things out. This very conference on Zoom, we've gotten really good at Zoom the last few days. There are tons, I know this because I've done this, there are tons of CE things you can do online if that meets the qualifications for your license. So if we're all staying home and not being able to treat patients, we should be able to find an online CE course someplace out there.
That's a great idea. Let's see. I think I now have a question as well. Dr. Byrne.
Yes.
What are you doing to keep the educational programs moving forward down at the school?
Well, we have really ramped up using resources that we have and using online learning. We have live streamed and recorded all of our lectures, and we're posting them on Blackboard, which is a learning management system. So the students can stay at home, listen to the lecture either live, or if it's recorded, they can listen to it later too. So we have both of those options. We're continuing to give all examinations on schedule using ExamSoft, and ExamSoft is another digital tool where we use it actually here at the school for the students to take examinations, and we're letting them use that and, as opposed to coming to school, although we usually use it here at school. We also have a few people that still remember the Scantrons, pencil and paper type examinations. We have rapidly converted all of those examinations to ExamSoft. So we want students to continue to progress as much as they can. We both use, like I said before, we've always used Blackboard and ExamSoft, so that's really good that they don't have a big learning curve there. We're creating Blackboard collaborative groups, so students continue to work in small groups, even though they're all around Richmond somewhere. You can put 9, 10, 11 students, and they can live chat and work on group assignments together. And for our D4s, which of course is a group that we really want to keep on track as much as possible, we're having them actually record and submit some of their work, like their D4 treatment planning competency. So that's been very good for us. There has been some challenges, of course, because all preclinical simulation coursework has been halted until further notice. So our students can't come into the preclinical labs to practice operative, prosthodontics, endodontics, or any of that. So we're recording the preclinical lectures so they can listen to them. And when we do start back up or ramp up, then they can be prepared to go right into the simulation lab. Again, we already talked about no patient care except emergency. And the good news, I really do believe, is that when we get back on track, because they've had these recorded lectures and because they've seen the procedures and the simulations, we can bring them back to the preclinical area pretty rapidly. It doesn't involve patient care or aerosol, so maybe we can even stagger coming back. So I want to have something positive here. And if we need to, we'll start using evenings and Saturday hours. We want to keep on track. It's challenging, but we're going to do it.
So what are students telling us they're most worried about, Dr. Healy?
As you would expect, dental students have all the same concerns that you have as practitioners, but these individuals are about to be our colleagues and have to complete their dental education. And the first thing on their mind is finishing their dental education in a timely manner, better known as graduation for them. But in addition to that, their licensure exam has recently been postponed and rescheduled for later in the spring, towards the very end of their semester. in addition to the licensure exam itself, is they were in the process of finding patients for that exam. And that has kind of been put on hold now since we stopped treating patients other than emergent care. So the other concern that they have is when they do get back, and when we do get back to treating patients, finding those patients that may be willing to be treated for their board exam. The ones that they have already looked at, they'll have to go back and repropose the dates and whether they were willing to come to the school to have care done here. The other thing that comes up, and my hope is that the answer is going to be yes, that the job offers that have been made to them as they look forward to completing their education are honored, even though we have a later graduation date. We're still unsure about residency programs, AEGDs, GPRs, and specialties, what the impact's going to be for maybe a later graduation date. Although residencies do work on a July 1, June 30th time period, we imagine there'll be some leniency for students graduating a little bit later. The other thing that comes to mind is really for us at the dental school, depending how late we may need to go into the summer with getting our D4s graduated, we do run the potential of perhaps having 5 classes here at one time with a D4 class that's slightly delayed in graduating and an incoming class that we hope to bring in a little bit later in the summer. For us, it's late July. Next slide, please. Of course, with the D3s, they have similar concerns with clinical progression and patient care, but we know that their patient care has been interrupted as well. Another concern, since they are D3s and they have not completed a full year of clinical education, keeping their own skills sharp and learning new things. As for D1s and D2s, they share a lot of similarities because they are preclinical in nature for the most part. As Dr. Byrne indicated, their exams and lecture delivery has been changed this year. For them, they are just beginning to develop skills preclinically, but nevertheless, that skill development needs to occur, and that has been interrupted. And we don't know if there's going to be some ramping up for them to develop new skills and refine the ones that they have already developed. And then, of course, for all students, we don't know what the financial aid and what support they may have if we do have an extended matriculation period for all these students, D1 through D4. The same could be said for dental hygiene students as well. All these issues that I talked about here apply to dental hygiene as well. Thank you.
Thank you. Well, that comes at the end of our kind of prepared questions to cover. Any thoughts from any of our team here or Dr. Reynolds, anything that you think we want to cover a little more or questions that's generated? I can tell you we have more questions than we have answers, and I'm sure you do too out there. And I'll let you close, Elizabeth, but I just want to thank the VDA for participating in this, and I think it's been very good. Hopefully it'll be good for the membership. I think it's also very, very good for us to kind of assemble this stuff and kind of get all our heads around a common base of knowledge. And we're using Zoom. As you can see, this was put on kind of ad hoc. So I'm sure the audio is not as perfect as you'd like it if it was done in the studio. But literally this idea was hatched a little before lunchtime yesterday afternoon, and it's now close to 3 o'clock today. So I really appreciate everything that everybody's done who's participated to help get this information out, because I think it's very critical. Because if we don't do something together as a community and as a population to slow this down, we're going to be in a lot bigger trouble than we are now. So Elizabeth, I'll let you close it out.
I want to reiterate my thank you to you and your team for being a part of this. I think that the scariest part is always the unknown. And I think that having the science which backs up what our decisions have been, the decisions we've made, really makes a difference. I would like to echo earlier, I think that for those who have not necessarily decided that ceasing their practice as of yet is important, I think this science does speak to maybe we can all take a step and maybe cut down to just emergent care for the time being. I'm sure the board will be listening to this. I'm sure the Virginia Department of Health will be listening. So the science says that that will help. Maybe a little bit of caution on the front end will limit what happens on the back end. So thank you all for everything that you've done to make this possible. We really appreciate it.